Hepatic encephalopathy and coma. Definition: Hepatic encephalopathy is a syndrome usually observed in patients with cirrhosis. Hepatic encephalopathy is defined as a spectrum of neuropsychiatric abnormalities in patients with liver dysfunction, after exclusion of brain disease. Hepatic encephalopathy is characterized by personality changes, intellectual impairment, and a depressed level of consciousness. Hepatic encephalopathy is a neuropsychiatric syndrome caused by liver disease. It is a life-threatening complication of liver disease, occurs with profound liver failure and may result from the accumulation of ammonia and other toxic metabolites in the blood. As it progresses, confusion is followed by coma. Epidemiology: approximately 35% of all patients with cirrhosis of the liver die in hepatic coma. Etiology: the exact cause of hepatic encephalopathy is unknown. However, it's usually triggered by a buildup of toxins in the bloodstream. This occurs when liver fails to break down toxins properly. The liver removes toxic chemicals such as ammonia from body. These toxins are left over when proteins are metabolized or broken down for use by various organs in body. The kidneys change these toxins into safer substances that are then removed through urination. When liver is damaged, it's unable to filter out all the toxins. Toxins can then build up in bloodstream and potentially get into brain. Toxic buildup can also damage other organs and nerves. Hepatic encephalopathy may be triggered by infections such as pneumonia, kidney problems, dehydration, hypoxia, or low oxygen levels, recent surgery or trauma, medications that suppress immune system, eating too much protein, medications that suppress central nervous system, such as barbiturates or benzodiazepine tranquilizers, electrolyte imbalance, especially a decrease in potassium after vomiting or taking diuretics. Pathophysiology: clinical scales for grading HE. A number of scales have been devised for the diagnosis of HE. The first of its kind was proposed by Parson Smith and colleagues in 1957. For patients with moderate to severe HE, the Glasgow Coma Scale can also be employed. Table 1, West Haven criteria for hepatic encephalopathy, HE. Stage: consciousness, intellect and behavior. Neurologic findings: 0. Normal. Normal. Normal examination. If impaired psychomotor testing, consider M.Sc. 1. Mild lack of awareness. Shortened attention span. Impaired addition or subtraction, mild asterixis or tremor. 2. Lethargic. Disoriented, inappropriate behavior. Obvious asterixis, slurred speech. 3. Somnolent but arousable. Gross disorientation, bizarre behavior. Muscular rigidity and clonus. Hyporeflexia. 4. Coma. Coma. Decerebrate posturing. M.Sc. Minimal hepatic encephalopathy. The West Haven classification table, Table 1. Stage 0. M.Sc. Previously known as subclinical HE. Lack of detectable changes in personality or behavior. Minimal changes in memory, concentration, intellectual function, and coordination. Asterixis is absent. Stage 1. Trivial lack of awareness. Shortened attention span. Impaired addition or subtraction. Hypersomnia, insomnia, or inversion of sleep pattern. Euphoria, depression, or irritability. Mild confusion. Slowing of ability to perform mental tasks. Asterixis can be detected. Stage 2. Lethargy or apathy. Minimal disorientation. Inappropriate behavior. Slurred speech. Obvious asterixis. Drowsiness, lethargy, gross deficits in ability to perform mental tasks, obvious personality changes, inappropriate behavior, and intermittent disorientation, usually regarding time. Stage 3. Somnolent but can be aroused, unable to perform mental tasks, gross disorientation about time and place, marked confusion, amnesia, occasional fits of rage, present but incomprehensible speech. Stage 4. Coma with or without response to painful stimuli. However, the terms that limit each stage of the classification are not clearly defined, and the metric characteristics of the stage are unknown. It is for this reason that other scales such as the Clinical Hepatic Encephalopathy Staging Scale, CHES, have been proposed. 16 The presence or absence of the 9 items on the CHES score may be helpful in eliminating inter-observer variability and in making a distinction between the various grades of encephalopathy. This staging scale, however, requires further validation. Minimal or subclinical encephalopathy. Patients with minimal hepatic encephalopathy, MHE, have a normal neurological examination, however they may still be symptomatic. Symptoms relate to disturbances in sleep, memory, attention, concentration and other areas of cognition. A classic sign of HE is a sleep disturbance. On a sleep questionnaire, disturbance is seen in 47% of cirrhotic compared with 4.5% of controls. A higher frequency of sleep disturbance in cirrhotic patients with MHE has been confirmed in studies using health-related quality of life questionnaires. Sleep disturbance in cirrhosis is not associated with cognitive impairment, thus it may not truly be an MHE symptom. Unsatisfactory sleep is associated with higher scores for depression and anxiety, raising the possibility that the effects of chronic disease may underlie the pathogenesis of sleep disturbance. Disturbances in cirrhotic may also be related to abnormalities of circadian rhythm. Defective memory may be a sign of MHE. Patients with MHE have impaired short and long-term memory. This impairment is predominantly related to deficits in attention and visual perception. Memory deficit of MHE seems to comprise short-term but not long-term memory impairment. This can be described as an encoding defect, in which memory recall is intact. Several cognitive statements and/or complaints have predictive value for MHE, including impaired psychomotor performance, I have difficulty doing handwork, I am not working at all, impaired sleep or rest, I spend much of the day lying down in order to rest, decreased attention, I am confused and start several actions at a time, and poor memory, I forget a lot, for example, things that happened recently, where I put things, etc. Cognitive impairment in MHE mainly affects complex activities involving attention, information processing and psychomotor skills such as driving a car, planning a trip, etc. whereas basic activities of daily life, such as shopping, dressing, personal hygiene, etc. are preserved. Patients with MHE had a significant impairment of daily functioning, such as social interaction, alertness, emotional behavior, sleep, work, home management, recreation and pastimes compared with cirrhotic patients who did not have MHE. Treatment with lactulose improved both cognitive functions and health-related quality of life. Improvement in the latter was linked to improvement in cognitive function. Clinical manifestations. Symptoms and signs of moderate hepatic encephalopathy may include difficulty thinking, personality changes, poor concentration, problems with handwriting or loss of other small hand movements, confusion, forgetfulness, poor judgment, a musty or sweet breath odor. Symptoms of severe hepatic encephalopathy are confusion, drowsiness or lethargy, anxiety, seizures, severe personality changes, fatigue, confused speech, shaky hands, slow movements, diagnostic evaluation, history taking, physical examination, blood tests. A complete blood count checks red blood cells, white blood cells, and platelets. A low red blood cell count indicates blood loss and a lack of oxygen. Blood tests may also be used to check blood levels of sodium, potassium, and ammonia. Having too much of these substances is a sign of impaired liver function. Liver function tests. Liver function tests check for raised enzyme levels. An increase in enzymes indicates stress on liver or liver damage. Electroencephalography, EEG changes associated with HE are high amplitude low frequency waves and triphasic waves. However, these findings are not specific for He. When seizure activity must be ruled out, an EEG may be helpful in the initial workup of a patient with cirrhosis and altered mental status. EEG studies are not required to make a confident diagnosis of He. Computed tomography, CT, and MRI. There are no diagnostic features of He on CT or MRI imaging. These studies are not recommended unless there is consideration of alternative or coincidental intracranial disease. Management. Medical management. Those with severe encephalopathy, stages 3 and 4, are at risk of obstructing their airway due to decreased protective reflexes such as the gag reflex. This can lead to respiratory arrest. Transferring the person to a higher level of nursing care, such as an intensive care unit, is required, and intubation of the airway is often necessary to prevent life-threatening complications, e.g., aspiration or respiratory failure. Placement of a nasogastric tube permits the safe administration of nutrients and medication. The treatment of hepatic encephalopathy depends on the suspected underlying cause, types A, B or C, and the presence or absence of underlying causes. If encephalopathy develops in acute liver failure, type A, even in a mild form, grade 1-2, it indicates that a liver transplant may be required, and transfer to a specialist center is advised. Hepatic encephalopathy type B may arise in those who have undergone a TIPS procedure. In most cases this resolves spontaneously or with the medical treatments discussed below, but in a small proportion of about 5%, occlusion of the shunt is required to address the symptoms. In hepatic encephalopathy type C, the identification and treatment of alternative or underlying causes is central to the initial management. Given the frequency of infection as the underlying cause, antibiotics are often administered empirically, without knowledge of the exact source and nature of the infection. Once an episode of encephalopathy has been effectively treated, a decision may need to be made on whether to prepare for a liver transplant. Diet. In the past, it was thought that consumption of protein even at normal levels increased the risk of hepatic encephalopathy. This has been shown to be incorrect. Furthermore, many people with chronic liver disease are malnourished and require adequate protein to maintain a stable body weight. A diet with adequate protein and energy is therefore recommended. Dietary supplementation with branched-chain amino acids has shown improvement of encephalopathy and other complications of cirrhosis. Some studies have shown benefit of administration of probiotics, healthy bacteria. Lactulose lactitol. Lactulose and lactitol are disaccharides that are not absorbed from the digestive tract. They are thought to decrease the generation of ammonia by bacteria, render the ammonia inabsorbable by converting it to ammonium, NH4+, ions, and increase transit of bowel content through the gut. Doses of 15 to 30 ml are typically administered 3 times a day. The result is aimed to be 3-5 soft stools a day, or, in some settings, a stool pH of 6.0. Lactulose may also be given by enema, especially if encephalopathy is severe. More commonly, phosphate enemas are used. This may relieve constipation, one of the causes of encephalopathy, and increase bowel transit. Lactulose and lactitol are beneficial for treating hepatic encephalopathy, and are the recommended first-line treatment. Lactulose does not appear to be more effective than lactitol for treating people with hepatic encephalopathy. Side effects of lactulose and lactitol include the possibility of diarrhea, abdominal bloating, gasiness, and nausea. In acute liver failure, it is unclear whether lactulose is beneficial. The possible side effect of bloating may interfere with a liver transplant procedure if required. Antibiotics. The antibiotic rifaximin may be recommended in addition to lactulose for those with recurrent disease. It is a non-absorbable antibiotic from the rifampicin class. This is thought to work in a similar way to other antibiotics, but without the complications attached to neomycin or metronidazole. Due to the long history and lower cost of lactulose use, rifaximin is generally only used as a second-line treatment if lactulose is poorly tolerated or not effective. When rifaximin is added to lactulose, the combination of the two may be more effective than each component separately. Rifaximin is more expensive than lactulose, but the cost may be offset by fewer hospital admissions for encephalopathy. The antibiotics neomycin and metronidazole are other antibiotics used to treat hepatic encephalopathy. The rationale of their use was the fact that ammonia and other waste products are generated and converted by intestinal bacteria, and killing these bacteria would reduce the generation of these waste products. Neomycin was chosen because of its low intestinal absorption, as neomycin and similar aminoglycoside antibiotics may cause hearing loss and kidney failure if used by injection. Later studies showed that neomycin was indeed absorbed when taken by mouth, with resultant complications. Metronidazole, similarly, is less commonly used because prolonged use can cause nerve damage, in addition to gastrointestinal side effects. L-ornithine and L-aspartate. The combination of L-ornithine and L-aspartate, LOLA, lowers the level of ammonia in a person's blood. LOLA lowers ammonia levels by increasing the generation of urea through the urea cycle, a metabolic pathway that removes ammonia by turning it into the neutral substance urea. LOLA may be combined with lactulose and/or rifaximin if these alone are ineffective at controlling symptoms. Nursing management. Nursing diagnosis. Deficient fluid volume related to bleeding, decreased intake and ascites as evidenced by physical examination. Ineffective breathing pattern related to hypoxia. Imbalanced nutrition less than body requirement related to GI adverse effect. Risk for injury related to loss of protective mechanism secondary to hepatic coma. Activity intolerance. Self-care deficit. Disturbed sleep pattern. Impaired verbal communication. Risk for aspiration. Impaired gas exchange. Impaired tissue integrity. Disturbed sensory perception. Interventions. Fluid balance must be balanced, hence should start intravenous therapy. Maintained and monitor to prevent further hepatic injury and reduced renal perfusion. Monitor vital sign frequently. Measure urine output hourly. Monitor electrolyte and acid-base balance because its disturbances such as hypokalemia and alkalosis may precipitate hepatic encephalopathy. Hepatic coma may create a multitude of problems for the client with encephalopathy. Prevent hypoxemia. To prevent and treat hypoxemia, attend to respiratory intervention like maintain airway. Prevent nosocomial infection. Prevent ammonia toxicity and hypokalemia. Prevention to the injuries. Complications. Brain herniation. Brain swelling. Increased risk of cardiovascular collapse, kidney failure, respiratory failure, sepsis. Permanent nervous system damage to movement, sensation, or mental state. Progressive, irreversible coma. Side effects of medications.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.